we are coming to you with an integrated discussion on a very, very important topic. It's again one of the most high yield topics for any exam that you're appearing for as a medical graduate. And what you need to know is an integrated picture. What happens is that you are, picking up bits and pieces from some subject, but we need to see the complete picture together. And that is going to be the goal of our discussion. We are picking up a question from DAMS question bank from DQB, which is in the clinical vignette session of the DAMS question bank. And we will do a discussion with both the, the neurological aspect, which Dr. Achin Mehra would be taking, and the pathological aspect, which Dr. Sanjeev will be looking at. And I will be telling you why and how of the radiological imaging in this particular disease. So today we will be doing a neurology case integrated from the DQB section. I hand over to Dr. Achin to take it forward from here.
Thank you, sir. Now, in this COVID pandemic, I've got a topic from America itself. A very common disease, which they say in their country is the Prion disease, also known as the Prion disease in India, right? Just the pronunciation is different, but the matter is the same. Now, to understand the topic better, I believe an MCQ will always help me out. The question reads like this: a 50-year-old woman began having double vision diplopia. She is also suffering with depression as an unsteadiness of her gait. Her body appears to jump in presence of a loud sound. Okay, she happens to see, we happen to see on MRI some basal ganglia hyperintensity in her case, and the CSF is normal or unremarkable. What is your likely diagnosis? Is it a case of Alzheimer's disease, a neurodegenerative common disorder? Is it a case of a rare neurodegenerative disorder like Huntington chorea? Is it a case of creutzfeldt-jakob disease? Or is it a case of temporal lobe epilepsy? Now, remember this, looking at such a question, there always should be some keywords in your mind, like what is the right answer and how to it. And the Prion and what is creutzfeldt? And are proteins which are up to an alternative conformation. Remember this, and they're self-propagating. That any protein that changes its own shape and propagates Is it a case of creutzfeldt-jakob disease, or is it a case of temporal lobe epilepsy? Okay, now looking at the question again, like person suddenly jumps on presence of a loud noise. I believe someone just bangs the door near you, will also start jumping. That is a typical myoclonus that we find. So one thing comes into my background, that myoclonus in a female patient with hyperintensity in basal ganglia, is it a case of CGD or not? To this, let's look into a disease which is known as a Prion disease. Remember this, the Prion are basically proteins which adopt to an alternative conformation all the time. And they are self-propagating. So any protein that changes its own shape and it is self-propagating is known to us as a Prion disorder. Now, in the Prion disorders or the Prion proteins that we have, don't forget that the Prion protein, the most important here is the PRPSC. The word SC came out from the disease in sheep, the Prion disorder that was diagnosed there, that is scrapie, and that in human being resulted in a CJD or a creutzfeldt-jakob disease. But other prions are also behaving in the same way. If you remember, A beta peptide is another protein that changes the shape and conformation to a beta plated structure, and it is self-propagating. If you remember, the A beta peptide results in which disease? The Alzheimer. And alpha-synuclein, another prion protein that results in Parkinson and multiple system atrophy, and tau protein that results in frontotemporal dementia, FTD. So remember, this is the prion protein that the PRP conformation or the configuration of it is not the only prion protein that we have. We also got A beta peptide with us, alpha-synuclein and tau proteins also. But remember the Prion disorders like CGD, if I look at, in human beings and animals are manifested. In human beings, one of the very famous and the prototype disease is creutzfeldt-jakob disease, or the CJD. Another one is a Kuru. Another one is Gerstmann-Straussman syndrome, or GSS. And of course, fatal familial insomnia, or FFI. In animals, we have got various disorders like as I told you, scrapie was seen in the sheep and the goats. Bovine spongiform encephalopathy is seen in the cow. And feline spongiform encephalopathy is seen in the cats. So few animal Prion disorders, you should at least know the names of them. Now, yeah, animals are not eaten in India so well, but in India, the China, they're always ready with a hot dog after eating the bat, of course. Now, creutzfeldt-jakob disease is sporadic, that it happens in a particular generation only, it's a sporadic CJD. Another type is a variant CJD. Another type is a familial CJD and iatrogenic CJD. Now, sporadic CJD is more common. It's seen in around 85% of the cases. The onset of this disease occurs at around 66 years of age. Death occurs within 4 months of time of the onset of the disorder. Variant CJD, the onset occurs at an early age, at the age of 29. Death occurs within 14 months of onset of the disease. So this person, comparatively to a sporadic CJD, has a longer life. And where was a variant CJD seen? It was seen in Europe, in youngsters especially, when they consumed the tainted beef over there. So there was a kind of a pandemic over there, not a pandemic, but an epidemic over there. And that was a variant CJD. Familial CJD is running down in the generation, and there is a gene that is known as the PRNPG on chromosome 20 that is responsible for this. They have got the early age of onset, yes. And remember, the word sporadic is something that you should know about, that suddenly, you start studying. And whenever your family member asks you to study, you study sporadically, once in a while. And when you study sporadically, your family members are really confused. What are you doing? Okay. And iatrogenic CJD, never forget, this is a very, very important topic again. Iatrogenic CJD comes via the corneal transplants. Yes. Contaminated EEG electrodes, the dural grafts, the human growth hormone therapy, and pituitary gonadotrophin therapy. So the few routes where the iatrogenic CJD can come into us are these. And whenever the thing like corneal transplant comes into my mind, a movie Andhadhun comes into my mind. Yes, something related to that only, the organ smuggling. And after watching that movie, I always felt I should give 50 rupees extra for the acting there, right? Now, clinical features of CJD, very important. It comes to us in a triad, that is a startle myoclonus, seen in around 90% of the cases. Like person will hear a loud sound or a clap, and then suddenly person will start jerking. That is a myoclonus, or a sudden jerk on hearing a loud noise or a clap is known as the startle myoclonus. Psychiatric symptoms, yes, are seen in them, like depression and psychosis, and dementia that occurs quite late into the disease, okay, not quite early symptom in them. Apart from this, there are non-specific symptoms in CJD patients seen, like fatigue, weight loss, and sleep disturbances. And cerebellar symptoms are also seen, with some visual symptoms. As I've explained, I've tried to put in the question also, the patient had some visual loss with diplopia. So some visual symptoms could also be seen in them. Now, if you know what is myoclonus, yes, it is a brief, rapid, shock-like jerky movement that we find is known as the myoclonus. Myoclonus can be of various types. While doing some activity is known as the action myoclonus. Like this person is trying to shift water from one glass to the other glass, and the hand keeps on shaking in between like this. So it seems to me like a tremor, but it is a shock-like jerky movement which intermittently appears like this on doing an activity known as an action myoclonus, right? And of course, the reflex myoclonus that I just now showed in the previous video, that the person hears a loud sound or a clap and suddenly the person starts jerking or has a shock-like movement, which is very brief, known as a reflex or a startle myoclonus. And there is something which is known as a negative myoclonus, where the tone of the body suddenly decreases, also known as a flapping tremor and hysterexis. Yes. Here we tell the patient to outstretch the hand like this, and he cannot hold there for a longer time. And there is decrease of tone in the hand muscles suddenly like this. The word negative comes because of this, because in normal myoclonus, the tone increases, but here the tone decreases. So it is known as a word negative myoclonus. And one thing that I'm very sure you must have ever felt is a hypnagogic myoclonus. Whenever you want to going to sleep and you see a dream like this, you suddenly wake up like this. So that is somewhere seen at the sleep onset, very often the hypnagogic myoclonus. Now going on to the investigation, they're very simple. Brain biopsy. Only when the MRI is inconclusive, we go for the brain biopsy. Now I request Dr. Sanjeev to pitch in, and sir can tell us something about the pathological features, how does the CGD actually happens, and what are the things that we've seen in the brain biopsy of these cases.
Thank you, sir. Thank you, Dr. Achin. I'll just have only few slides here, 2 slides to show about this. Okay, so what exactly happens in a Prion disease is, what exactly happens in Prion disease is, so we are talking about, just a minute, so I'm not able to see my, yeah. So we are talking about, so the prion protein that is there. So this prion protein, wild type, in every one of us, wild type, that is what can happen. So PRPSC can be happening, but it will be a very slow process that will be happening. So if there is a mutation that is present, so if there is a mutation, and this will become, increased probability of producing a PRPSC. And apart from this, so this is because of the mutation that can happen. And other than that, can be an inoculation or an injection, so I was talking about iatrogenic, or maybe injection also can be cause. And this PRPSC, what does it do is, this PRPSC, which is a beta platelet structure again, which will be insoluble, it cannot be removed by any enzymes, it cannot be removed by any inflammation. And this abnormal protein, whenever it binds to a normal protein also, so it will convert this, and this is what we call it as a propagation of the PRPSC. And when such propagation happens, there will be large aggregates that will be produced, and these will get deposited in the neuronal body, that is in the gray matter basically. So if you look at it, it is in the neuronal body, and neurons will start dying. So the only difference between this and the other types like the Alzheimer's, where A beta is being deposited, difference is this will be a very rapid deposition happening, whereas in A beta and all, there will be a very slow one. That is why the onset of duration of the disease and also progression, fatality, etc. will be very different between these two. Yes, so this is about the basic pathogenesis of the PRPSC, that is the scrapie. SC stands for the scrapie. So now let us look at the brain biopsy finding. What will you find? There is something called as a spongiform change. A spongiform change, the name itself is suggesting sponge-like appearance. So basically we already know in the pathogenesis, inside the neuronal body there will be multiple vacuoles that will be produced, and multiple deposition of this PRPSC. These are the multiple vacuoles. These multiple vacuoles that are there, this is what is giving rise to spongiform change. Spongiform change is a common for all the Prion diseases. This is what is because of accumulation of the PRPSC. Specifically, if you are looking at one of them, that is the Kuru. In Kuru, you will end up seeing such type of plaques, which are amyloidotic plaque, amyloid-like plaques basically. So this will be PAS positive in nature. So Kuru plaques will be PAS positive. And these are the only 2 things that will be seen on the biopsy of the Prion diseases. And again, back to you, Achin sir.
I think so. Before I proceed, I would request Sumesh sir to enlighten us about the neuroimaging part in this disease, because this is something very important for exam also.
Thank you, Dr. Achin, and thank you, Dr. Sanjeev, for an excellent discussion so far. And I think, before we look at, before we go at a possibility of doing a brain biopsy in a modern era, we would always look at an MRI, and we'll look at, some characteristic findings. What I'll do here is I will tell you, a few important lines, important words, and important images which can be asked in the exam as well. So, Achin, are you able to see my screen?
Yes, sir. It's visible, sir.
Okay. So number one thing to remember is you will see T2 or flare hyperintensity in your basal ganglia, predominantly in your caudate nucleus and in your putamen. So you'll see T2 flare hyperintensity in the basal ganglia area. Remember, caudate nucleus and putamen hyperintensity. And typically when it comes to us in a radiology question, they will always have a corneal transplant or a history like that written in your question. But second thing, and even more important, is that diffusion weighted MRI today is more sensitive to pick up the changes than a routine T2 or a flare MR. So it would be in your exam as an undergrad or a resident, they will always give you diffusion weighted MRI. So the first image that you see here is a flare MRI, and these are your hyperintensities. Hyperintensity in the putamen, in your caudate nucleus. But look at how easy it is to pick those up on a diffusion weighted MRI. So this is DWI, diffusion weighted MRI, hyperintensity in the caudate nucleus and the putamen. Even before that, there is something which is of very importance to you. When you heard the pathology discussion, the pathologist was talking about the spongiform changes, the cortical spongiform changes which you see in Prion disease. Now, we can appreciate those changes as bright signal on diffusion weighted MRI in the brain cortex. So I want all of you to look at this. Are you able to look at the brain cortex is shining like a ribbon? It is so bright on this diffusion weighted MR, we will call it cortical ribboning, which is believed to be one of the early MRI signs of CJD, where you have cortical ribboning. So bright signal on diffusion weighted MRI, cortical ribboning on DWI are seen in CJD. But like Dr. Achin and Dr. Sanjeev had mentioned to you that you could have a variant CJD, which is also the bovine spongiform encephalopathy, where the involvement of the posterior pulvinar nuclei of the thalamus is considered more of a sign of variant CJD, pulvinar sign or pulvinar involvement, which is often said to resemble the hockey stick like appearance. So we can just say pulvinar sign is also the thalamic involvement or thalamic nucleus of pulvinar nucleus of thalamus involvement is seen in variant CJD. It's also seen in sporadic, but more typical of variant CJD. So these are the things to keep in mind, that when you have a typical clinical history and you have a MRI showing you cortical ribboning or basal ganglia hyperintensity, especially in the caudate and the putamen, or pulvinar hyperintensity, thalamic hyperintensity, we think of CJD as a diagnosis. And I'll ask Dr. Achin to take it forward from here.
Thank you, sir. Okay. As somewhere we saw that the disease is more often being diagnosed through an investigation like MRI, and I was very clear the brain biopsy is only done when the MRI is inconclusive. There's another role of CSF that they put in various books, but you remember the CSF is usually normal in these patients, although there is elevated stress protein that is 14-3 and 3, but that thing is non-specific for diagnosis in such cases. And something important, the EEG. Yes, EEG is another important topic which is asked on this CJD. A part of it, that is repetitive high voltage triphasic spikes are seen in these patients, right? And nowadays we're getting some questions on EEG in various exams, especially the Central Institute exam. And whenever you see an EEG coming in the exam, yes, you go blind over it. Let's try to remove your blindness by this andhadhun topic, Prion or CJD. Spikes, something that we understand is in kind of an elevation or a depression which could be seen in the normal EEG pattern. If the spike goes in one direction only, it is known as monophasic, like it goes up or down, positive or negative, it is monophasic in one phase. If it goes up and down both, it is biphasic. If it goes up and down and up, like our COVID curve, it's a triphasic. And it goes up and down, which will happen in COVID pandemic again, is a polyspikes. So there are various spikes which are seen in an EEG pattern. Remember this, in a case of CJD, yes, you will find 3 spikes, up, down, and up and down. Okay, so this kind of a spiky change, that is a triphasic spikes, are seen in patients of CJD on the EEG. So somewhere if you can locate this on the EEG recording, it's good, because most of the questions nowadays, they will always come with a background history and with the EEG like this. So you should not be frightened, and whenever you read an EEG in the exam, yes, you feel very happy, like a miracle, right? Now, most important is that the decontamination of the CGD prion has to be done. As I emphasized, the disease can be through a route iatrogenic. So how do you decontaminate the things that you have used in a prion patient? By autoclaving at the temperature of 134 degrees Celsius for 5 hours time, or treating the same thing which you want to decontaminate with sodium hydroxide for several hours. Now, this has been a question somewhere in microbiology they keep on asking about. How will you decontaminate the CGD prions? And unfortunately, there is no effective therapy for this disease. There's no cure for it. It needs a dead end, right? Now, other prion disorders, never forget them as well. That the long name that we have is the Gerstmann-Straussler-Schechner syndrome. It is an autosomal dominant disorder that we find. It comes at an early age. It is slowly progressive disease. Death occurs within 5 years of onset. Ataxia and spasticity are clinical symptoms seen in it. And then fatal familial insomnia. Remember that. As the word insomnia comes in, there is insomnia with some dysautonomia seen in them. Dementia comes later in them. Lesion is something somewhere seen at the anteromedian nucleus of thalamus. This has been a question recently in PATH. And what is fatal insomnia that you guys also have? Whenever you look at the mobile, you cannot sleep. It's very fatal. It can be in the family tree also. Don't worry, that's a different story. But this is a disease which is a prion disease known as a fatal familial insomnia. And Kuru, yes, Kuru is something very famous. I'm very sure you must be knowing about Kuru, that it comes from the human cannibalism that has not been practiced now in some of the New Guinea island tribal population over there. So if you're trapped in the island, don't feel that these people are going to come and help you. Run away from there. They can be, they might eat you, and if you have a disease, they can have a Kuru disorder, right? Okay. So let's look at the question again. A 50-year-old woman began having a double vision and a diplopia. She is suffering with depression and unsteadiness of gait. She appears to jump in presence of a loud noise. MRI shows a basal ganglia hyperintensity. Likely diagnosis. Alzheimer? No. Alzheimer will always have a history of memory loss as a predominant symptom in them, and that's not there in the question. And most important, basal ganglia hyperintensity doesn't fit into that. Huntington chorea at a 50-year-old, I agree, could happen, but the background of the family history of this disease should be there. And these person jumps in presence of a loud noise is not chorea, it is myoclonus, right? So the best answer is CGD or creutzfeldt-jakob disease. Another option is temporal lobe epilepsy, which can come to us with a focal seizure with impaired awareness. So that will be in the background of the clinical history provided to us. So of course, the myoclonus, the startle myoclonus or the reflex myoclonus was the key word here to diagnose a case of CGD. As Sanjeev sir said that in patients of prion, we have the brain turning into a sponge-like thing, a spongiform degeneration. I always felt my brain should be like a sponge. I should absorb everything which comes to me, okay, so that I can become a multitasker, right? But if you develop a spongiform degeneration in the brain, I believe the brain is totally waste. It really doesn't help you too much. Okay.
So wonderful, Dr. Achin, with the end of the entire discussion was so interesting that I don't think anybody will forget this question later on. Spongiform cortical degeneration is seen in CGD. Thank you so much, Dr. Achin, for a wonderful discussion, and Dr. Sanjeev for a great discussion on pathogenesis. Now, I would also like to use this opportunity when I have both of you with me today to, guide the students about the preparation. Like, I'll start with Dr. Achin here. Dr. Achin, there is a lot of talk about the pattern change now, that the exam pattern will be changing. There will be an exit exam, licensing exam soon. And I also want to use this opportunity to tell that soon you will also see licensing exam for dental graduates, and we'll also see for nursing graduates also in future. That is the vision of the government right now. So, Achin, tell the students like what should be their approach, with a changing pattern.
So I agree. The examiner and the exam might change, but the topics are going to remain the same. First of all, the old topics that we keep on reading from the first year of MBBS, same things will be asked again. They're not going to ask you something, a KBC kind of a question or a history or a geography question over there. So my advice for the students is not to panic first, because first of all, the topics are getting repeated even in a new exam. So whenever the examiner wants to make a new kind of a paper, he'll always look into the last 10 years paper and try to find out topics which are more frequently asked there and try to put a question on that. So and secondly, the clinical question need an emphasis in form of clinical vigilance. So you always should have a keyword in your mind to diagnose a correct disorder. So you should always have this three principle, which I always feel while solving a clinical question. What is the answer? Why it is an answer? And third, most important thing, why not the other people? If you are able to satisfy yourself on these three kind of mottos, I believe your answer in a clinical question will never go wrong. Okay.
Dr. Sanjeev, I also want your take on the style and Sanjeev, you would agree that, we have been talking about integration in, I think, for last 15, 20 years now. I think, Sanjeev and me, I think we made in 2013, we made a series on radiology, pathology combined. And today the entire country is talking about integration. And, I'm so happy that, at least the medical education is going in the right direction with integration. So Sanjeev, tell us that how a student should approach a clinical vignette.
Yes, for this, I would always say, so, their basis should be always right. I always keep telling this, to all my students. I mean, unfortunately, that this happens many a times. When you go to medicine, you forget pathology, and when you're in pathology, you do not know what is medicine, and that should not happen. When you are in pathology, you should be knowing what is happening in medicine, and when you go to your medicine, you should never forget your pathology. I mean, not only pathology, all the basic sciences, but pathology and pharmacology, they more integrate with the medicine. Basically, that's why I'm using this analogy here. And I would see in the future, especially with the competency-based curriculum already introduced into the MBBS, and see what they have introduced in 2K19. As you said, we made our first video back in 2013. If I'm not wrong, we can check it on the YouTube also. It is somewhere in 2013, I guess. So we were already evolved into this kind of long back, and this is the MCI has introduced in 2K19. And especially with this, DAMS is going to be giving one of the best hosts for the students, because see what is happening is many of my friends are in medical colleges. When I speak to them, they're like, see, we are already 40 years, forget about me, my professor is 55 years, you tell him to switch to a competency based, suddenly how does he switch it? I mean, that's going to be very tough for from teaching point of view in most of the medical colleges, and DAMS is the one which is giving you this from last 5 years also. And when they have shifted this, I would say the top people who are the thinking tank, they have already got shifted to the competency based curriculum. And we can see that with the questions that are there in the last 2 years, the questions are all integrated. So what is happening with the students is the questions, the testing is going to happen in an integrated manner, but they are not learning it in an integrated manner. That should not happen. So that is where DAMS pitches a lot, and we have given the best thing of integration right from in everything. I mean, anatomy with neurology, with radiology, with pathology, everything. So futuristically, I would say students should start reading basics well and start integrating either by themselves if they are good enough, or start looking at videos that we are giving, or at our classrooms. Of course, there's a lot of integration that's already done.
And I want to use this opportunity to tell the listeners that in 2021, we would be having a lot of integrated sessions in our curriculum itself. Now, what will happen every month, every few weeks, we will look back and help you, because although we tell the students, Sanjeev, that we tell the students to integrate, but what I feel, integration at a medical student level happens when they listen it from the mentors. Because what happens is at that level, they have not enough clinical experience to actually integrate. So as mentors, as teachers in DAMS, we would help you look back every few weeks. There will be sessions like this happening on your app, where will help you to integrate things. There will be classes, and we are all very hopeful that with the vaccine now in picture, very soon you will be having full-blown face-to-face sessions, and so we will integrate and the technology with the traditional. So there will be like traditional classrooms happening, there will be live sessions happening on your app. We'll integrate everything together, and we'll integrate different disciplines also together for you. On this note, we wish you all the best. Do let us know in the comment section if you enjoy these sessions on the DAMS in the YouTube channel. Thank you very much.